Welcome to the HQI, Be Smart About Antibiotics, Striking a Balance Between Sepsis and CDI. My name is Richard, and I'll be your operator for today's call. At this time, all participants are in a listen-only mode. Later, we will conduct a question-and-answer session. Please note that this conference is being recorded. I'll now turn the call over to Candy Hamner. You may begin.
Good afternoon, everyone. My name is Candy Hamner, and I'm one of the improvement consultants with HQI. On behalf of the Maryland Stopping Sepsis and Long-Term Care and the Virginia Stopping Sepsis and Virginia Hospitals and Nursing Homes Special Innovation Projects, as well as the Nursing Home Improvement Networks in Maryland and Virginia, we would like to welcome you all to this special, extremely informative HQI webinar, Think Smart About Antibiotics, Striking a Balance Between Sepsis and CDI. We find today that leadership and clinical staff in many of our nursing homes are struggling with the question, is sepsis prevention in direct conflict with antibiotic stewardship and our efforts to reduce CDI? Additionally, when we reviewed 10 of our infection prevention assessments that were completed by our Maryland Stopping Sepsis participants, it was clear that there was a need for better understanding about the management of antibiotics in a long-term care setting. We hope this webinar today will point out the synergy between the moving parts and show you that we can accomplish all of these initiatives. Before I introduce today's speaker, Katie Richards, I have a few housekeeping items. While we hope this session will answer all of your questions, please feel free to type questions in the chat as the session is progressing. The lines are muted now. However, at the end, the lines will be open for open questions and answers. Lastly, evaluation will be posted right near the end of the webinar, and we would really appreciate your completing that before you depart. A link for the handouts was included with the reminder email that came out yesterday. If you don't have those handouts, go back and look at that link, and you can print those out. Now I'd like to introduce our speaker, Katie Richards. Katie Richards is an improvement consultant with Health Quality Innovators, HQI, and she's been working on healthcare-associated infections and antibiotic stewardship. Prior to coming to HQI, she was the Healthcare Association's Infections Program Coordinator at the Maryland Department of Health and Mental Hygiene. There, she helped create the Maryland Campaign for Appropriate Antibiotic Use, CAUSE, a statewide collaborative dedicated to antibiotic stewardship. Katie, I'm going to turn it over to you.
Thank you, Candy. So today, as Candy already alluded to, I'm going to give an overview of antibiotic stewardship. I'm going to discuss upcoming CMS regulations. I will describe the epidemiology of Clostridium difficile infection and sepsis. I will explain how sepsis prevention goes hand in hand with antibiotic stewardship. And lastly, I'm going to discuss some of the current initiatives Health Quality Innovators, or HQI, is currently participating in. Okay, let's dive right in. In the simplest of terms, antibiotic stewardship seeks to improve antibiotic use, which includes not giving antibiotics at all when unnecessary, or choosing the smallest gun in your antibiotic arsenal to get the job done. In more technical terms, the Infectious Diseases Society of America, or IDSA, defines antibiotic stewardship as coordinated interventions designed to improve and measure appropriate use of antibiotics by promoting the selection of optimal antibiotic drug regimen, dose, duration of therapy, and route of administration. And the Association for Professionals in Infection Control and Epidemiology, or APIC, describes stewardship as a coordinated program that promotes the appropriate use of antibiotics, improves patient outcomes, reduces antibiotic resistance, and decreases the spread of infections caused by multi-drug-resistant organisms. The aim of stewardship includes optimizing the 4 Ds, that is, choosing the right drug at the right dose for the right duration of time, and de-escalating the therapy to target the specific pathogen. De-escalation means if you start out with a bazooka, but then realize you're just trying to target a rat, you can downsize to a handgun, unless you're up against the monster rats that we have here in Baltimore. I'm not a gun nut, I promise. I just really like gun references when it comes to antibiotic stewardship because we are at war with antibiotic resistance. The goals of an antibiotic stewardship program includes reducing resistance, decreasing or controlling costs, and optimizing patient safety. So let's start with discussing antibiotic resistance. Taking a step back, I think this is a great graphic on how antibiotic resistance and Clostridium difficile, or C. diff, infections happen. Everyone is colonized with germs, especially in our gut, called our microbiome. When we get sick and take antibiotics, the antibiotics kill the bacteria causing the illness, but they also kill the good bacteria that just likes to hang out and protect us from other infections. However, the antibiotic-resistant bacteria or the C. diff bacteria are not killed by the antibiotic. And now that the antibiotic has taken care of the competition, the drug-resistant bacteria can go and take over. And sometimes bacteria are nice enough to share their defenses against antibiotics with other bacteria, resulting in even more drug resistance. The CDC has outlined 4 core actions to fight drug resistance. First is preventing the infections in the first place, which will reduce the amount of antibiotics that have to be used. Prevention takes many forms. It includes getting your vaccines, hand washing, practicing safe food preparation, and using antibiotics only as directed. Second is tracking the spread of antibiotic resistance so that we can be mindful of the risk factors causing resistant infections and develop strategies to prevent infections and drug resistance from spreading. Third is antibiotic stewardship, which is what I'm talking about today. Stopping even some of the inappropriate and unnecessary use of antibiotics in people and animals would help greatly in slowing down the spread of resistant bacteria. Lastly is developing new drugs to keep up with resistant bacteria and developing new lab testing to track the development of resistance and ensure you're getting treated with the right antibiotic. Moving on to the costs associated with antibiotic use. Numerous studies have shown that implementing an antibiotic stewardship program can save significant healthcare dollars, especially in the acute care setting. This data is local, too. A University of Maryland study showed implementation of an antibiotic stewardship program saved a total of $17 million in a span of 7 years at one institution. After the program was discontinued, antibiotic costs increased by 32% in the first year and continued to increase the following year. Now, I know that I'm talking to a bunch of nursing home staff members right now, and honestly, there are actually very few studies, one way or the other, on the financial benefits of antibiotic stewardship in this setting. However, the evidence does suggest that nursing homes would also see these cost savings through the use of antibiotic stewardship. For example, following evidence-based guidelines using shorter courses of therapy saves money, and so does de-escalating to the quote-unquote cheaper antibiotics. Lastly, antibiotic stewardship is a patient safety issue. Antibiotic misuse contributes to antibiotic resistance, as I already discussed. It can also lead to increased adverse drug events and drug interactions. In fact, antibiotics remain the leading cause for adverse drug event emergency department visits among adults aged 20 to 64, and allergic reactions were the most common adverse events from antibiotics. Not to mention the fact that antibiotic use carries the risk of Clostridium difficile infection, which I will discuss in a little bit. Antibiotic stewardship applies to many healthcare settings, and I'm sure this doesn't quite cover all of them, but it includes the pharmacies actually dispensing the antibiotics, doctors' offices, ambulatory surgical centers, dialysis centers, urgent care centers, probably one of the worst offenders, in agriculture, and even in dentists' offices, which was surprising to me when I first started learning about antibiotic prescribing, but their prescribing rates are up there. And the one common denominator is you and me, the patients going from one healthcare setting to another. Now let's bring this back to the nursing home setting and why antibiotic stewardship is important in this setting. Antibiotics are among the most frequently prescribed medications in nursing homes, with up to 70% of residents in a nursing home receiving one or more courses of antibiotics in a year. Similar to findings in hospitals, Studies have shown that up to 75% of antibiotics prescribed in nursing homes may be unnecessary or inappropriate. And I already discussed the specific antibiotic-related complications in the patient safety slide, but the harms from antibiotic use are more severe for the frail and older adults receiving care in nursing homes. Everyone is in charge of antibiotic stewardship. Prescribers need to be aware of the current prescribing guidelines to make sure that they are prescribing the right antibiotics and only when necessary. Pharmacists have to guide antibiotic prescribing, providing feedback to prescribers, and will even catch when there's a bad drug interaction. The nurses are usually the frontline staff, recognizing the infections that do, or more importantly, do not require antibiotics. The infection preventionist role, as their title indicates, is to prevent the spread of infections, especially drug-resistant infections, and I can guarantee you that C. diff is public enemy number 1 for most IPs. Information technology can even play a role by providing the data on antibiotic prescribing, infection rates, and costs back to your program if you are lucky enough to have access to an IT department. The lab is important for testing of drug resistance and alerting prescribers when a highly resistant organism is identified, needing a stronger antibiotic. And it's also important for prescribers to follow the drug resistance testing to know if the antibiotics initially prescribed are actually effective. Facility administrators direct resources to antibiotic stewardship and set the culture promoting antibiotic stewardship in the facility. Lastly, patients, families, and communities are key as well. Residents need to be sure that they are taking an antibiotic exactly as prescribed, because not doing so contributes to resistance. And they also need to be mindful that certain infections do not need antibiotics, and they shouldn't pressure their doctor into prescribing an unnecessary antibiotic. The tricky part for some healthcare facilities is how to actually implement antibiotic stewardship programs. In 2014, the CDC released the core elements of hospital antibiotic stewardship programs. Next year, in 2015, the CDC released the core elements of antibiotic stewardship for nursing homes. And just last month, they released the core elements of stewardship in outpatient settings. Hospitals and nursing homes share the 7 same core elements. And the outpatient core elements are pretty much the same 7, just condensed into 4 so it doesn't look quite as daunting. To go into more detail specific to the nursing home setting, the core elements of antibiotic stewardship in nursing homes include leadership commitment or leadership committing resources to a formal antibiotic stewardship program, accountability, meaning identifying the accountable facility champions to oversee the stewardship program, drug expertise, having the connection via a consulting pharmacist or an affiliated hospital with antibiotic stewardship experience, action or implementing policies and interventions to improve your antibiotic use, tracking or monitoring antibiotic use and outcome measures, reporting those tracking measures back to your staff, and education, and that's education of staff, of prescribers, of patients, of residents, and of families. If you're not sure where to start, the CDC created a 2-page checklist for the core elements of antibiotic stewardship in nursing homes found on the CDC's GetSmart website. You can use this as a good baseline assessment. In fact, you may already be doing activities in your facility unrecognized as stewardship. Now, I have a more acute care-focused background, so when talking about antibiotic stewardship and long-term care, my first question was, what is already being done? In 2012, the Maryland Department of Health and Mental Hygiene, or DHMH, conducted a pilot survey of 16 long-term care facilities in Frederick and Washington counties. They talked with DONs, ADONs, or IPs, and found that while only 2 facilities stated that they have an official antibiotic stewardship program, nearly every facility had already implemented some elements of antibiotic stewardship in their facility, which is what the checklist on the previous slide can help you to identify. Health Quality Innovators also recently conducted infection control assessments among Maryland nursing homes participating in our Stopping Sepsis and Long-Term Care Special Innovation Project. The assessments were based on the CDC's infection control assessment tool for long-term care facilities and included a section specific to antibiotic stewardship. Among the 10 facilities that responded, you can see that they are in pretty good shape when it comes to the first 3 core elements, including leadership support, identifying accountable leaders, and having access to antibiotic prescribing efforts. But there is still more work to be done and an opportunity for improvement when it comes to written antibiotic prescribing policies and staff education training. This is a slide that I've just included for your future reference, which includes some great resources on antibiotic stewardship specific to the long-term care setting. I already went over a lot of the core elements materials, but I also want to highlight the ARC, or the Agency for Healthcare Research and Quality Guide, which includes an SBAR, Situation Background Assessment Recommendation tool for suspected UTI, as well as pocket cards with C. diff guidelines and antibiotic prescribing guidelines. Moving on to the new CMS regulations, which I think if you printed them out would look a lot like the desk in this cartoon. For long-term care, CMS Regulation 81 FR 688, also known as the CMS Mega Rule, took effect November 28th. With regards to antibiotic stewardship, you have a little more time, but not much. The Antibiotic Stewardship Requirement is effective November 28th, 2017. Now, the Mega Rule states that long-term care facilities are required to develop an infection prevention and control program that includes an antibiotic stewardship program. Further, the stewardship program must include antibiotic use protocols and a system to monitor antibiotic use. At this point, we're still waiting on specific interpretive guidelines for the antibiotic stewardship requirement, but this doesn't mean wait until next November to get your stewardship programs up and running. You need to start thinking about them now, in your spare time, along with all the other daunting new requirements in the Mega Rule. To tie the Mega Rule back to the core elements, your stewardship program must include antibiotic use protocols, and that's your action, and a system to monitor antibiotic use. And a system to monitor antibiotic use is your tracking and your reporting. So you can see that they align. I'm pretty sure that they did this on purpose. And now I'm going to move on to Clostridium difficile, also known as C. diff, also known as CDI, for Clostridium difficile infection. C. diff is a spore-forming gram-positive bacillus. It is shed in feces and often transmitted via environmental surfaces because the spores make it so difficult to kill in the environment. It is the most common microbial cause of healthcare-associated infections in U.S. hospitals, making it public enemy number one, as I said. The biggest risk factor for acquiring C. diff is previous antibiotic exposure, hence why C. diff links to antibiotic stewardship so closely. Other risk factors include use of proton pump inhibitors, gastrointestinal surgery, healthcare exposure, serious underlying illness, immunocompromised status, and age. I recently heard C. diff referred to as an infection of the W's, of the three W's, in that it mostly affects whites, women, and widows, indicating older age. C. diff is bad news, and infection can lead to pseudomembranous colitis, toxic megacolon, perforations of the colon, sepsis, and even death. Symptoms include watery diarrhea, fever, loss of appetite, nausea, and abdominal pain. In about 20% of patients, diarrhea may actually go away when other antibiotics are stopped. But for the rest of the patients, appropriate antibiotics are needed. While metronidazole is not approved for treating C. difficile infections by the FDA anymore, it has been commonly recommended and used for mild C. diff infections. However, it should not be used for severe C. diff. In that case, vancomycin is recommended normally. Whenever possible, treatment should be given by mouth and continued for a minimum of 10 days. For patients with multiple recurrences of C. diff, fecal transplant may be indicated. In 2013, the CDC released a threat report of all of the drug-resistant threats facing the United States, categorizing these drug-resistant pathogens into concerning, serious, and urgent threats. Only 3 pathogens made the top urgent threat level, and they were Clostridium difficile, carbapenem-resistant Enterobacteriaceae, or CRE, and Neisseria gonorrhea. Inappropriate antibiotic use contributes to all 3, but most notably in the healthcare setting to CRE and C. diff. The CDC has actually updated the numbers in this graphic from the threat report, and they are now saying that C. diff results in 500,000 infections a year, with approximately 15,000 deaths directly attributable to C. diff. Now, I'm an epidemiologist by training, so I live in the numbers. This is what you bring back to your nursing home administrator to explain why C. diff prevention efforts, including antibiotic stewardship, is important. Among the 500,000 infections a year, over 100,000 infections are among nursing home residents. Additionally, 80% of the 15,000 deaths a year are in the 65 years and older population. In fact, 1/3 of all C. diff cases occur among people over 65 years of age, and 2/3 of all healthcare-associated C. diff cases occur in this population. The CDC recently created national burden estimates based on surveillance data in 10 states, Maryland being one of them, accounting for age, sex, race, and testing type. Based on 2011 data, among the 293,300 estimated healthcare-associated cases of C. diff, about 1/3 were hospital onset, 1/3 were community onset but still healthcare-associated, and 1/3 were nursing home onset. The next year, the CDC used 2012 data from the same 10 states to specifically explore the burden of nursing home onset C. diff. Now, you can read these stats on your own. I'm sure by now you're getting tired of looking at numbers. But I do want to highlight that over half were diagnosed in-house in the nursing home, and over 3/4 of nursing home onset C. diff cases had documented receipt of antibiotics in the 12 weeks prior. Bringing it back to local data, the Maryland Department of Health and Mental Hygiene conducts population-based surveillance for C. diff in Washington County, Frederick County, and the counties on the eastern shore of Maryland. This table breaks down the over 7,000 cases of C. diff identified since surveillance began in 2011 by location of onset. You can see that almost half of all the healthcare facility onset C. diff infections among this population were in the long-term care setting. Just to define the other acronyms on this slide for your reference, CO is community onset, CA is community associated, and HCFA is healthcare facility associated, which does include some long-term care population as well. For the Virginia folks on this webinar, I'm sorry I don't have similar data for you. This data is specific to the Emerging Infections Program, which only Maryland is a part of. Okay, this is my last slide on C. diff, talking about prevention. So obviously my first bullet is going to be about antibiotic stewardship, because antibiotic stewardship programs have been shown to decrease C. diff rates. But apart from that, you need to rapidly identify and isolate patients with CDI, use gloves when entering residents' rooms and during resident care. Preventing contamination of the hands via glove use remains the cornerstone for preventing C. diff transmission via the hands of healthcare workers. And make sure you perform hand hygiene after removing gloves. Because alcohol does not kill Clostridium difficile spores, use of soap and water is recommended over alcohol-based hand rubs. Implement an environmental cleaning and disinfection strategy, ensuring adequate cleaning of environmental surfaces and reusable devices, especially items likely to be contaminated with feces and surfaces that are touched frequently, using EPA-registered disinfectants. Continue precautions until diarrhea ceases, and even several days beyond, because C. diff-infected patients continue to shed for a number of days following cessation of diarrhea. And now I'm going to switch topics and talk about sepsis, which is something C. diff can actually lead to. Sepsis is caused by infection, and certain infections obviously lead to sepsis more often. Sepsis is a complication caused by the body's overwhelming and life-threatening response to infection, which can lead to tissue damage, organ failure, and even death. According to the Society of Critical Care Medicine, there are 2 additional classifications of sepsis, which include severe sepsis, which is acute organ dysfunction secondary to infection, and septic shock, which includes hypotension, not reverse fluid resuscitation. Sepsis can happen to anyone and can occur from even a minor infection. However, some people seem more likely to get sepsis than others. Those more at risk include people over 65, babies under 1, the immunocompromised, those with underlying chronic conditions, people who have suffered burns, trauma, or have wounds, and people with urinary catheters. In fact, nursing home residents with urinary catheters are more prone to bacteremia and septicemia. There is no single sign or symptom of sepsis. It is a combination of symptoms and the presence of infection. The HQI Seeing Sepsis Toolkit has an early detection tool that uses the 100s as a way for nursing home staff to easily remember what to look for. Is their temperature over 100? Is their heart rate over 100? Is their blood pressure below 100? And does the resident just not look right? Tell the nurse, screen for sepsis, and notify the physician immediately. The graphic on the right comes from the CDC and contains signs that any family member can look for, including chills, extreme pain, clamminess, confusion, shortness of breath, and high heart rate. The most important treatment for sepsis is antibiotics to fight the infection. Every hour a resident in septic shock does not receive antibiotics, the risk of death increases 7.6%. Many patients receive oxygen and intravenous fluids to maintain normal blood oxygen levels and blood pressure. Other types of treatment, such as assisting breathing with a machine or kidney dialysis, may be necessary, and sometimes surgery is required to remove tissue damaged by the infection. HQI, in partnership with the Minnesota Hospital Association, developed an algorithm for skilled nursing facilities to follow when they suspect sepsis. If a resident has suspected infection and 2 or more SIRS criteria, which includes those 100 from the previous slides, that is a positive screen for sepsis, and you should plan for review of advanced directives, contacting the family, and notifying the physician. If transferring the resident to the hospital, you should prepare a transfer sheet, call an ambulance, call in a report to the hospital, and report the positive sepsis screen. Now, I was actually just in a Maryland hospital over the weekend, and I heard them announcing over the PA system, code sepsis, emergency room, ambulance bay 5, ETA 4:45 p.m., which was kind of neat for me to hear, preparing this presentation for you today. But just know that it is really important to let the hospital know what's coming so that they can adequately prepare and have their sepsis team ready. If the resident stays in the facility, consider options that are in agreement with the resident's advanced directive, which could include labs and treatment options. If the resident progresses into multi-system organ dysfunction syndrome, at that point, consider transfer to another level of care, whether that's hospital, palliative, or hospice. All right, coming back to the numbers again, over 1.5 million people in the U.S. are diagnosed with sepsis every year, and 70% of patients with sepsis had recent healthcare exposure. To describe the characteristics of patients with sepsis, the CDC reviewed medical records of patients in 4 New York hospitals with administrative codes for severe sepsis or septic shock. The results were recently released in the August 2016 Vital Signs report, and they found that among adults with sepsis, 35% had lung infection or pneumonia, 25% had a UTI, 11% had a gut infection, and 11% had a skin infection, so think wounds. Sepsis is the leading cause of death in U.S. hospitals. 1 person dies from sepsis in the U.S. every 2 minutes. And while many causes of death are decreasing due to advancing treatment options, sepsis-related deaths increased 31% from 1999 to 2014. Bringing it closer to home, our amazing data analysts at HQI pulled Medicare beneficiary data on sepsis from Maryland and Virginia using 2015 data. In Maryland, there were 2,938 patients sent from skilled nursing facilities and admitted to hospitals with sepsis present on admission. Of those, 637, or about 22%, died in the hospital, and an additional 404 died within 30 days of discharge. To put this in other terms, approximately 1 in every 3 patients transferred from skilled nursing to hospital with sepsis died in hospital or within 30 days. Now, looking beyond that setting, there were 21,999 total patients admitted to Maryland hospitals from anywhere with sepsis. About 14% of them died at the hospital, and 3,157, or 14% of them died at the hospital, and an additional 2,264 died within 30 days of discharge, resulting in 1 in every 4 admissions with sepsis dying in hospital or within 30 days of discharge. Now let's talk about Virginia. In Virginia, there were 3,416 patients sent from skilled nursing facilities and admitted to hospitals with sepsis present on admission. Of those, 780, or about 23%, died in the hospital, and an additional 683 died within 30 days of discharge. So that comes out to 1 in every 2.3 patients transferred from skilled nursing to hospital with sepsis died in hospital or within 30 days. The CDC works to prevent infections that could lead to sepsis through support for many programs, including vaccination against diseases caused by germs like pneumococcus, meningococcus, and influenza, smoking cessation programs because smokers have a higher risk of pneumonia, and pneumonia is one of the leading infections leading to sepsis, strategies that prevent healthcare-associated infections, and research on prevention of infections that can cause sepsis. This is a nice graphic that the CDC provided on what patients can do to help prevent sepsis. Healthcare providers can prevent infections by following infection control guidelines, educating patients and families on the need to prevent infections, knowing the signs and symptoms of sepsis in order to be able to act fast and order proper testing and start antibiotics immediately, and change therapy as needed after reassessing the patient's condition. Okay, so I've gone over antibiotic stewardship, which seems to say don't use antibiotics. And I've gone over sepsis, which says start antibiotics immediately or your patient will die. I know this sounds pretty contradictory, and this year's CDC sepsis campaign was actually met with criticism from antibiotic stewardship advocates. It seems like I'm talking out of both sides of my mouth, but you need to remember that antibiotic stewardship does not mean don't use antibiotics. Antibiotic stewardship is about using antibiotics appropriately, which actually aligns with sepsis guidelines. So I'm a band geek, and I am all about music and harmony. I've included on this slide the stewardship policies that work in concert with sepsis treatment efforts. First is require your prescribers to document dose, duration, and indication of antibiotics so that they can be modified or even discontinued as needed based on additional information. Another action you can take is developing facility-specific treatment recommendations. For example, restricting certain classes of antibiotics, limiting the duration of antibiotics, developing treatment recommendations for infections like pneumonia or UTI, or providing prescribers with local susceptibility information called antibiograms, which help guide treatment decisions while waiting for the culture and susceptibility results. The idea is to help clinicians prescribe smarter, not refrain from any prescribing at all. An antibiotic time-out is a formal process designed to prompt a reassessment of the ongoing need for and choice of an antibiotic once more data is available. Nursing homes should have a process in place for a review of antibiotics by the clinical team 2 to 3 days after antibiotics are initiated to answer key questions such as, does this resident have a bacterial infection that will respond to antibiotics? If so, is the resident on the most appropriate antibiotic dose and route of administration? Will the resident benefit from additional infectious disease or antibiotic expertise to ensure optimal treatment of the suspected or confirmed infection? Can the spectrum of the antibiotic be narrowed or the duration of therapy shortened, i.e. de-escalation? Now, I wanted to see how stewardship and sepsis fit together in real life. So I did a little literature review looking for publications about antibiotic stewardship and sepsis outcomes. I ended up pulling about 29 articles that directly applied. The outcome in a majority of the articles reviewed was sepsis-associated mortality. 6 of those articles found that non-appropriate empiric antibiotic treatment actually increases mortality, which is why I highlighted the importance of treatment guidelines on the previous slide. 9 studies found that de-escalation either significantly lowers or does not even affect sepsis mortality, and 4 found that antibiotic stewardship either significantly lowers or does not affect sepsis mortality. You may be wondering why it's significant to include the fact that the interventions did not even have an effect on mortality, and that's because they often resulted in other benefits, including cost savings, length of stay, and antibiotic resistance. So if stewardship is not affecting your sepsis mortality, and it's still resulting in improved patient outcomes, that makes a pretty compelling argument to me. And now I want to quote the authors and highlight a few of the more interesting findings I came across along the way. Montero et al. Found that adequate antibiotic treatment prior to ICU admission was a protective factor for mortality in patients with severe sepsis or septic shock. They go on to say that efforts should be directed to assure the correct administration of antibiotics before ICU admission in patients with sepsis. Appropriate de-escalation of empiric antibiotic therapy is a fundamental component of antibiotic stewardship. However, many clinicians are concerned about the late detection of bloodstream pathogens, which is a common reason why antibiotics are not de-escalated. To provide literature in favor of de-escalation, you can cite Hardo et al., who found that few true bloodstream infections are detected after more than 48 hours of culture incubation. Clinicians may adjust empiric antibiotic coverage at this time with little risk for subsequent bacterial pathogen detection. As I said previously, many studies found that de-escalation either decreased or has no impact on sepsis mortality. Since de-escalation affords an opportunity to limit overuse of broad-spectrum antibiotics, it should be considered as an option in clinical practice. Salahuddin et al. Also examined factors related to failure to de-escalate treatment and found that current de-escalation practices reflect physician reluctance when dealing with complicated, sicker patients or with drug resistance or fungal sepsis. Now here's the money shot and the big takeaway. Integrating an antibiotic stewardship program may increase physician confidence and provide support towards increasing de-escalation rates. Just a month and a half ago, the CDC presented an abstract at ID Week showing that antibiotic stewardship actually helps to prevent sepsis from occurring in the first place. The authors used hospitalization and pharmacy data from a hospital drug database and studied patients who were diagnosed with sepsis on readmission within 90 days of discharge, looking at prior antibiotic use in the index non-sepsis visit. The study included over 9 million patients from 473 hospitals, and 0.6% of those had sepsis during readmission. They found that patients are at an increased risk for sepsis after taking any antibiotic and have an 80% higher chance of developing sepsis or septic shock after taking high-risk antibiotics in the hospital, which includes 3rd and 4th generation cephalosporins, fluoroquinolones, lincosamide, a beta-lactam/beta-lactamase inhibitor combinations, oral vancomycin, or carbapenem. They also found a dose-response relationship between antibiotics and a risk for sepsis. In fact, regardless of the antibiotic used, patients on antibiotics for more than 2 weeks had a 2-fold increased risk of developing sepsis. The authors concluded that the observed increased risk for subsequent sepsis following receipt of antibiotics, including a dose-response effect, supports the idea that microbiome disruption confers increased risk for subsequent severe infections. What's going on locally? Currently, there are large initiatives in both Maryland and Virginia addressing antibiotic stewardship. When I was at the Maryland Department of Health, my boss and I together started CAUSE, the Campaign for Appropriate Antibiotic Use, and I've been very fortunate to be able to continue my relationship with the campaign after moving to HQI. CAUSE is currently working with Maryland hospitals and nursing homes to encourage proper antibiotic use and decrease drug resistance by promoting and providing assistance with implementing the 7 core elements in these settings. Hospital recruitment was in late summer, early fall, and I think we're up to about 37 or so Maryland hospitals committed to joining the cause. Nursing home recruitment is ongoing as we speak. Virginia is also starting a statewide antibiotic stewardship campaign as a subgroup of the Virginia HAI Advisory Council. The campaign aims to reduce multi-drug resistant organisms across the healthcare spectrum through antibiotic stewardship. They are having a statewide kickoff February 1st, and I know they've been rounding up a really great group of speakers for the event. At the regional level, meaning across Maryland and Virginia, Health Quality Innovators has an antibiotic stewardship affinity group consisting of multidisciplinary subject matter experts discussing current efforts in our state and exploring ways to align efforts where possible. HQI is also gearing up for an outpatient antibiotic stewardship initiative, which will be providing support to outpatient facilities in implementing the 4 core elements of antibiotic stewardship. We will be targeting ambulatory surgery centers, emergency departments, dialysis facilities, outpatient clinics, physician offices, and urgent care centers for recruitment, and have been able to use claims data to identify the high prescribers in each state. I also want to highlight some of the other efforts being conducted by our Quality Innovation Network Quality Improvement Organization, which is, or QINQIO, which is HQI, which is our team. So as you know, the triple aims are better health, better care, and lower costs. And you can read under these claims, we list the objectives of our current QINQIO contract. All of our initiatives fall within these categories. The Nursing Home Improvement Initiative is under better care, and we will be continuing very intentional work on reducing healthcare-acquired conditions. The Nursing Home Initiative team is working with the community team now on antibiotic stewardship as well. Many of you are already members of the HQI Nursing Home Improvement Network. In the Nursing Home Improvement Network, we focus on helping nursing homes attain excellent outcomes in the long-stay quality measures. Additionally, we are working with many nursing homes in Maryland and Virginia to reduce and prevent sepsis as well as C. diff. While Maryland nursing homes are already up and running in year 2 of the Maryland Stopping Sepsis campaign, the Virginia Stopping Sepsis campaign is just getting started. And I've been asked to remind any participants listening to complete your infection control assessment and team contact list and return them to Deb Smith. I know it was a long time ago in this presentation at this point, but if you remember the slide with the red and green results of the current Maryland nursing home stewardship activities, I'm asking you to complete your infection control assessment so in the future I can have a slide with Virginia data as well. As I previously mentioned, HQI is working with nursing homes on a C. diff prevention collaborative. The participating nursing homes are receiving education and consultation on determining baseline rates to help identify the best areas to focus process improvement efforts, using the National Healthcare Safety Network reporting system, and implementing best practices for infection prevention and antibiotic stewardship. We have 52 nursing homes in Maryland and 55 nursing homes in Virginia participating in this exciting project. If you are a participant, stay tuned, as I'll probably be talking to you again in the future about how best to implement antibiotic stewardship in your facility. I guess I'm volunteering for that, Teresa. And that was my last slide, so thank you very much for your attention, and thank you, Candy, for inviting me to speak today. Here is my contact information should you think of any questions following today's webinar. And Richard, we can now open the lines up for any questions.
Thank you. We will now begin the question and answer session. If you have a question, please press star, then 1 on your touch-tone phone. If you wish to be removed from the queue, please press the pound sign or the hash key. If you're using a speakerphone, you may need to pick up the handset first before pressing the numbers. Once again, if you have a question, please press star, then 1 on your touch-tone phone. Standing by for questions.
And I have a question in the cause commitment where it says that facilities will identify at least one metric for measuring success. Can you define a metric?
Yes, we've been purposefully vague with that metric. So we are asking facilities to track antibiotic use in whatever way they are capable. We aren't even trying to standardize that at this point. So we are asking facilities to track their antibiotic use and provide that, keep that data internal so that we can use that to measure success in the antibiotic use rates. Additionally, we are tracking implementation of prevention efforts and outcome measures such as C-diff, which through some health departments and NHSN reporting we'll have access to.
Okay, thank you.
You're welcome.
Once again, for any questions or follow-ups, hit star then 1 on your touch-tone phone. And I'm showing we have no questions in queue.
Okay. Candy, do you have any?
No questions. No questions in chat. At least not at this point. No questions in chat.
Okay. Well, then I think that concludes today's webinar. I thank everyone for your participation.
Thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating. You may now disconnect.